When we consider top-down or step-up approaches, we consider the factors that are likely to lead to progression or be associated with progression. As I've mentioned, extensive disease, patients who already have complications such as strictures or fistula, individuals who have deep ulcerations, cigarette smokers, for example. In those individuals, we really take a shared decision-making approach with the patients that identify the risks and benefits of each approach. As I've outlined, they include medical therapies that are oral treatments that do require monitoring, as well as the biologics with or without immunomodulators. The risks of either step-up or top-down approach include the risks of the different therapies. In particular, corticosteroids have been identified as the biggest risk factor for patients with inflammatory bowel disease, including Crohn's disease, because steroids have been associated with the biggest risk of infection, as well as mortality in the setting of Crohn's disease. The other factors that we would consider in determining the individualized treatment include whether or not patients have a history or family history of malignancy, their risk aversion to infections or a tiny risk of lymphoma, their preference for either intravenous or subcutaneous administration, as well as the frequency of administration of either sub-Q or intravenous formulations is going to make a difference. An example of a patient for whom I might use a step-up approach would be an individual with newly diagnosed Crohn's disease, perhaps of the ileum or the ileocecal area, with superficial ulcerations and none of the signs of severe progression. In those individuals, I may start with a non-systemic steroid such as budesonide and just treat them symptomatically. But it's become very important in our treatment approach to, as I say, trust but verify. We go beyond symptom control because we've learned that symptoms are insufficient to predict disease progression. So in that individual that I would start with budesonide, I would first watch their symptoms over the first several months and make certain that they are improving. But then after 3 to 6 to 12 months, I would do another procedure to demonstrate that we're actually getting healing and lack of progression. If that individual, for instance, developed deeper ulcerations or was not effectively improved according to their symptoms, then I would more rapidly escalate into more of a top-down approach with a biologic therapy. When we talk about shared decision-making with our patients, that decision from the patient's perspective really comes from their background. And as I've mentioned, risk aversion. If individuals are very concerned about side effects, in particular malignancies, that may move us in one direction or another in selecting an appropriate therapy for the individual. Likewise, the addition of an immunomodulator, such as a thiopurine or methotrexate, can reduce the immunogenicity and improve the outcome of patients treated with some biologics such as infliximab and perhaps adalimumab. On the other hand, that requires their own therapeutic monitoring for the immunomodulator, blood counts for patients treated with thiopurines, as well as liver enzyme testing, and in particular, individuals who are going to receive methotrexate need monitoring of their liver enzymes as well.